For our discussions, I'm very pleased to have with me Dr. Faisal Shuaib, Executive Director and Chief Executive, National Primary Healthcare Development Agency. Thank you so much, sir, for joining us.
Thank you, and good evening, viewers.
The Director for National Urban Reproductive Health Initiative is Dr. Mojisola Odeku. She also joins us today. Thank you so much for coming. Thank you for inviting me. Mr. Emmanuel Ananida is a Senior Technical Advisor with PASS, which is an indigenous health advocacy organization. Thank you, sir, for coming.
Good evening, and welcome, viewers.
And finally, Mrs. Ruby Leo, a reporter that specializes in health matters, working with Daily Trust newspapers. Thank you, ma'am, for coming.
Thank you so much for inviting me.
Okay. Dr. Faisal, I'd like to start with you. In that report, we saw a nurse talking about the cost of primary health care for people in rural areas. It's a little bit confusing because the general belief tends to be that primary health care should be free. So I want to start from that basis. Should we be paying for primary health care?
Right. So there's a lot of variability when you move from one state to the other. The ultimate aim, of course, is that we should have universal health coverage, and that for basic healthcare services, such as obtained in primary healthcare centers, that they should be free. Right, and that is the general direction of the current administration, that we have a situation where people do not have to pay out of pocket for basic healthcare services, and that these services should be of good enough quality. They should be equitable, that is to say, they should be available wherever people live.
So as a matter of policy, people are not supposed to pay for the basic stuff?
I would not say that categorically, right? Okay. So there's a lot of variability. So in some states, right?
What determines the variability?
Well, it depends on the local conditions in the states, right? Okay. So the federal government has a policy of achieving universal health care coverage, right? Mm-hmm. And what we're trying to do is hopefully when the Basic Healthcare Provision Fund is appropriated this year, right, we'll be able to increasingly make funds available to the primary healthcare centers.
Okay, so let's rewind and start from the beginning, because
right.
I think part of the problem is even understanding the way primary healthcare is structured. Right. I understand a bit like the way we have our governance. We have sort of at the local level the primary healthcare. At the state level, you have what is called the secondary healthcare, which is the government hospitals, general hospitals, and then the teaching hospitals are the. So first of all, who funds them? Where is the money for primary health care coming from? Is it from the federal government, is it from the states, or is it from the local government?
So originally, when it was conceptualized, primary health care was supposed to be domiciled in the LGAs. But what has happened over the course of the last few years is that we've seen a fragmented approach whereby the local government is involved, the state government is involved, and the federal government is involved. And this is what led the federal government to develop that policy of primary health care under one roof, where we are now saying that instead of having this kind of fragmented approach to primary health care, we have a consolidated, one authority-based mechanism whereby all primary health care services will now be managed under the state primary healthcare development agencies. And this means moving all the resources, both financial and human resources, to the state primary healthcare agencies.
You still haven't answered the part of the confusion is that you get a federal budget
right. that
says, this is dedicated to health.
Right.
We've got the Healthcare Act that says there's a 1% of the consolidated that is supposed to go to health.
Right.
But then we also know that state governments also have in their budget a health budget, at least the majority of them. So I'm trying to understand the funding and how it works, and therefore who is in charge, who would we hold responsible, for example, when things go wrong. Because often that's part of the problem. If you don't know who is in charge, you don't know who to go to and how to address these sort of issues.
That is my point precisely. So primary health care is supposed to be within the ambit of the local government areas. But as you well know, a lot of local governments are moribund. They don't even have the funds to fund primary health care, right? So you now have a situation where the state government now chip in and say, okay, we're going to manage the primary health care centers, right? But you also know that the federal government also builds primary health care centers, provides some of the resources. That is the fragmentation I'm talking about. But if you're going to go back to basic principles. Ideally, primary health care should be within the purview of the local government areas.
Let me bring in Dr. Mojisola Odeku. Under what currently exists, is the system broken, or is it sort of problematic but can be fixed?
Well, the current status, like the ED primary health care enumerated, is a status of confusion, unclear delineation of roles and responsibilities. Ideally, it can be fixed, like you said. We just need to go back to the basic. The basics is primary health care is the responsibility of the state and the LGA. The federal is supposed to provide a roadmap and an enabling environment, like a TA kind of technical assistant kind of approach. If you look at it really, the fund that the federal government is spending on PHC cannot deliver what we want to deliver. The states and the LGA must put their money there. Where is health produced? It is produced in homes and communities. We tend to look at the system as structure. It's much more beyond that. So when we invest in creating health at the household and linking the responsibility at that local level, LGA and state, they are the one that has the mandate to deliver it.
But let me bring in Mr. Emmanuel here. It is true, though, what Dr. Faisal said, that in the past, when the federal government had left the issue of primary health care to local governments and to states, things have not really quite worked out. And it is for this reason that they felt the need for an intervention, and the agency, for example, that he heads is supposed to do certain things. What are your views regarding this?
Thank you very much. That is where the problem is. We will not get it right until the right thing is done. Let's go back to basics. Nigerian Constitution recognizes, the concurrency of health, with federal government, state government,
yes,
and government. Primary health care for local government, secondary health care for state government, and tertiary health care for federal government is not a law. It's a policy. And as a policy, it's difficult to enforce. That's number one. Number two is that we are using moral persuasion and cajoling, including blackmailing, in enforcing it.
Please explain what you mean by that.
What I mean is that something that is not a law, and you are expecting it to be implemented, you are using the moral persuasion. Please let us do it because it is for global good. It is for your own community good. Having said that, you will not expect the local government to be able to discharge adequately on the primary health care provision as long as there is the currency of the resource responsibility mismatch. 80% of healthcare problems are supposedly at the local government level, at the primary healthcare level. Where just between 15 and 20% are at the top of the roof. But 80%, more than 60% of the resources are at that roof, and you are giving less than 20% of the resources to somebody who is supposed to sort.
All right, I'm going to have to take a break, and when we return, we'll carry on this very engaging conversation. Don't go away.